the end of your day,
Yeah, it's perfect.
although the beginning of mine, and if anyone has any questions at any time, just feel free to make them now or at the end. Okay. That is my research funding. I have some grants to look at low value care, actually, from Arnold Ventures and the Greenwall Foundation. So Albert, you mentioned the viewpoint, and as you all well know, because I think it was particularly early onset in Italy and very difficult, and COVID really changed the world for everyone in the last, since last January, and particularly was focused in internal medicine because, you know, the disease was sort of internal medicine based, and there were so many different manifestations of the disease that we saw. You know, some remember clearly when it started, and there were people that said it would just be like a flu, and then of course it turned out to be much more deadly than the flu. And most unfortunate, and I know that my colleagues or your colleagues and mine in Milan had particularly serious and very early understanding of how deadly this disease was. There were protein, so many manifestations, and we really had a lot to learn about the best way to treat this, and it really seemed to happen almost overnight. And I would say we're still learning about the disease and now about the treatments and the vaccines. But the focus of treatment was all in internists, and you know, we had many patients to take care of now with hypoxia, with renal failure, with myocarditis. And as Alberto mentioned, I'm a cardiologist, and we've had a lot of debates and controversy about the incidence of myocarditis, and now the incidence of myocarditis after the mRNA vaccines. But before the vaccines, we had a lot of discussions and debates about how common myocarditis was in young people who got COVID based on some imaging studies. And then the thrombosis issues, and we're still trying to understand the best way to treat thrombosis and the best anticoagulation regimen. In terms of, I'm going to move all this. The pressing clinical issues, so I said we really needed to determine what was the best way to treat modalities. All of a sudden, hospitals were being stretched beyond capacity. And then there were a lot of issues, as you know, about personal protective equipment. And so I think, you know, it really was a very big challenge because, frankly, none of us were quite prepared for a pandemic. It really drove home the importance of, I think, public health infrastructure, of hospital infrastructure, and of being ready to increase capacity quickly. And then it also brought a lot of issues in as to how do we learn quickly. And, you know, things that I really think about for my whole career anyway is when are treatments ready for use and how strong should the evidence be? Because before COVID, most of my research, and that really the choosing wisely, is on looking at treatments that have gotten into clinical use without having good evidence of benefit. But now we have a pandemic where we're desperate to, you know, to treat people and to make improvements in their care and their health. And how quickly should we accept a treatment as working? You know, should we change our evidence standards because of the pandemic? So there were lots of challenging aspects besides the difference in severity, with some people being mildly ill and some people being very seriously ill, in the unprecedented number of deaths from this pandemic. There also, I think, was the big and really scary problem that people could be infectious before they had symptoms, because I think with use of personal protective equipment, masks, and staying away from people who had a cough or other kind of symptoms, in general, we would feel protected against flu and other infectious diseases, yet it became clear that COVID was transmissible before people had symptoms. So another challenge. Of course, there were no randomized clinical studies to give us any guidance, and so that made it a lot more complicated. We had a lot of observational data. And frankly, because of the nature of the observational data, it was very hard to make any kind of conclusions because there were always reasons why certain people, for example, got selected to have steroids. Of course, we do have methods for trying to do really strong analyses of observational data, but they're still limited because of the lack of randomization. And so we had a chance to sort of explore how quickly or how well we could do randomized trials. I frankly think that we had more opportunities than we took advantage of because some of the big trials that enrolled where people were just so anxious to get hydroxychloroquine, and in the recovery trial, where this really was an opportunity because there were so many patients presenting with COVID that if we had a national or international infrastructure for enrolling patients, randomizing and collecting the data and analyzing it in real time, I think we could have actually learned a lot more, a lot sooner than we did by kind of taking a step forward and 2 steps backwards frequently because we were trying to learn from observational studies because of the concern and the urgency of treating so many sick patients. And so just sometimes even when things seem urgent and we should move ahead without data, I'm still not sure that we really do save any time by doing that, because when we move ahead without data and then give patients either treatments that haven't been shown to work, or we're not collecting the data in any organized way so that we can't learn from it, we haven't really moved the ball forward. We did have some interesting studies on mechanical ventilation. I think at first, of course, when patients were so sick, particularly with respiratory illnesses, there were a lot of intubations, and then data began emerging that intubations were actually seeming to make the patients worse. They were associated with higher mortality rates. And then, of course, there were all the issues with concerns about running out of ventilators, having very limited supplies. But the good thing was this drove a lot of interest in looking at non-invasive methods and ways that we could ventilate and get patients oxygen without having to intubate them. And so there was some very interesting work. One of the articles was published in JAMA Internal Medicine on prone positioning, where it seemed that if you were patients that were able to lie on their stomach actually had increases in their oxygenation. And so that was rewarding and exciting to us to be able to publish that study, because it was a way to improve oxygenation without ventilation and without the problems and the limits of the equipment in ventilation. The pandemic also pointed out the need for intensivists. You know, we needed a lot more doctors who were able to take care of patients in intensive care units. A lot of retired or non-practicing physicians ended up providing care or coming out of retirement so that they could help take care of patients, which was great. But I know, and talking and reading some of the articles that we got from trainees, there were a lot of trainees who felt particularly stressed. I mean, it was a very stressful time for everyone, but I think for the trainees who were not in internal medicine, but maybe were in ophthalmology or radiology, but had gotten pulled into the internal medicine wards in New York and perhaps in Italy when the early pandemic was just overwhelming in terms of need for more doctors. But I think because of the high mortality rates, particularly early on, and their lack of training to take care of very sick ICU patients, I think it created a lot of psychological stress for the doctors, particularly, as I said, the young trainees who were put in those situations. The pandemic actually also reminded us that we need to have a better way to do medical licensing. At least, I'm not sure how it's working in the EU in terms of, I believe there's, you can go from one country to another. In the United States, I can only practice in California or wherever I'm licensed. And that created another problem because doctors were eager to volunteer if they had, as I said, retired or had, were working for industry, but now wanted to do clinical work, but were limited to only offering their services in the state where they were licensed. And often that was not the state with the greatest need. So I think there was really incredible public spirit shown by the medical profession, but it also showed us how we could improve our ways to be flexible in medical capacity. The morbidity from COVID, of course, was very high, and we think that the rates of infection and death, particularly early on, were probably underestimates. This was a paper that was published in JAMA Internal Medicine last year, which by doing a very sophisticated analysis, showed that the actual infection rate was probably 6 to 24-fold higher than the number of confirmed cases. And it showed the importance of doing active surveillance, particularly early on when we were trying to limit the spread of COVID, and the importance of PCR testing and identifying asymptomatic or minimally symptomatic people, because as we know, those people are often infectious. So we really had a very steep learning curve with the COVID pandemic. And this shows the estimation of the excess deaths that were associated with COVID in the US. And as I certainly don't have to tell you, it's just been staggering numbers. And certainly we hope that we're now on the flat curve, but as you know, there's a lot of concern about the Delta variant and the other variants that have now emerged. The pandemic also exposed a lot of inequities, particularly in the United States in our healthcare. And it was clear that people in lower income neighborhoods who had lived in more crowded housing often were in service jobs where you had to be in person, like restaurant workers or grocery store workers. And of course, most of the restaurants were closed, but in jobs where people were unable to work remotely were more likely to get COVID and to suffer from serious adverse effects, including dying from COVID. And that, again, for the home healthcare workers, that was another very big problem, was how to take care of the elderly and the disabled who were particularly vulnerable to COVID. The isolation was very difficult for everyone, but particularly for the elderly. And there were just a lot of trade-offs. And we really learned how inadequate some of our institutional care is for older patients. And I think that's something we've struggled with for many years. And I hope that we're able to make some improvements in our ability to perhaps take care of people at home, improve home health care and wages for home health care, and have learned about better provision and better supplies of personal protective equipment. I think the visitor bans were particularly hard for hospital patients, for terminal patients, and for the elderly, because I think seeing people is really an important part of good health. There's a clear correlation between social connections and staying healthy. And with the bans that had to be enforced because of the infectious nature of COVID, it was very hard for so many people, but particularly the very young, I think, and the very old. We did have some breakthroughs, I think, on personal protective equipment, and we first of all learned that the masks worked, and while the N95s at first were thought to be the mask that you had to have, we learned that there were alternatives to N95s, and that cloth masks or double masking with simple masks was also effective. But I just wanted to wrap up because, as Alberto mentioned, we really recognize the importance of choosing wisely and using resources appropriately in healthcare. And waste is a huge problem in the US healthcare system. It's, I think, well over $1 trillion a year. And that's before the FDA approved this latest Alzheimer's drug, which is another wild question on what that means in terms of health and what that means in terms of medical expenditures in the US. But the pandemic, almost overnight led to a marked reduction in use of services. And I remember on faculty meetings and with my colleagues, talking about how we were going to be able to provide care for all the patients with COVID. And frequently what I heard was, well, we're only going to do testing that's really necessary, for other patients. And I thought, well, why aren't we always doing only testing that's really necessary for other patients? It was just remarkable to me how many times I heard that. The thought that in order to free healthcare resources and healthcare equipment to devote to care of patients with COVID, we would restrict our other use of the equipment just to necessary procedures, thought was something that we really should be doing every day, whether or not there's a pandemic. There was certainly, seemed to me, a clear implication that sometimes we're doing procedures that are not necessary. And now that we're recovering from the pandemic, and I hope that we will have an opportunity to look at, for example, what was the impact of this reduction in non-necessary services, and perhaps we don't need to see an increase, once we're past the pandemic era, and that we should, look at the rates, the outcomes. How did people do? Did diseases did heart attacks stay flat or increase or get worse in terms of outcomes? Cancer screening, I think, is a big one. A lot of people didn't go for elective cancer screening like mammograms or colonoscopy. And I think it's really important that we try to look at that data and see whether it had any impact in terms of did cancer rates change at all, and did cancer outcomes change at all? Because there's I think a big issue that with cancer screening, we're diagnosing a lot of early cancers that would not have actually caused any problems for people in their lives, but the actual diagnosis of these early cancers does cause problems because, first of all, it gets people very worried about being a cancer patient, but it also leads to procedures, chemotherapy, radiation that people probably or possibly did not need and would have been just as well off without. And so I think in the aftermath, we really have the opportunity to look at what care is really necessary and what is not, and more appropriately use our resources judiciously so that we can better take care of all of our population and not concentrate a lot of care on a few and have so many people without access to the care that they need. And so I do think it helps us to get back to sort of examining our principles of less is more. This was the editorial that my colleague Deborah Grady and I wrote back in 2010 when we launched the Less is More series, and that just questioning the idea that if some medical care is good, more care is better. And I think because of the pandemic, where we really were forced to give less care to many people so that we could have the resources to take care of the COVID patients, is a good time to sort of re-examine how we think about our resources and look at the actual data. And I am excited that we'll be able to do that. I wanted to wrap up by sharing the pictures of my lovely city and Italy. I hope any of you who would like to visit, we would love to see you in San Francisco. These are some of our famous hills in the city and the painted ladies, the Victorian houses. And then I don't have to show you the beautiful pictures from Italy. We're very pleased to read, and you can let me know if this is correct, but my understanding is that the rate of new infections in Italy remain low and that a quarter of the population is now vaccinated. In California, we have just lifted entirely the restrictions as of June 15th. And it's remarkable. I was out this weekend biking, and there were just so many people outside, I think, enjoying the ability to be outside and without masks for the first time in a year and a half, although there are still a lot of masking rules for indoor activities. So let's see there, wrap up. I think there are certainly some similarities and some differences in Italy and Europe and the United States. I'm hoping that we are going to see everywhere, and particularly in the US, where I think we have more waste clearly than anywhere in the world, more emphasis on cost containment and on downsizing. And that I think the pandemic really was a wake-up call, and I'm hoping that it's going to increase our funding for public hospitals, for health reform along the lines of better using our resources. And of course, the whole question of having a strong public health infrastructure, because there have been a lot of questions about the inadequacy of the Centers for Disease Control, the CDC, to respond to the pandemic. The communication issues really made things so much worse, with very unclear messages coming across. And I think all of that is related to an underinvestment in public health infrastructure and public hospitals. I think we also are the challenges of adequate personal protective equipment, the pressures on intensive care and the need for intensivists, and the burden on low income and healthcare workers worldwide. So thanks very much for inviting me. I'm sure it's the end of the day in Italy, and I'm happy to have any questions, or just thank you very much for sharing your conference with me.
So Rita, thank you so much for this presentation, and it's very interesting. I think that you talked about several points, several issues that are very important and very interesting. So just a technical comment that if there are any questions, all the people can put the question in the chat so we can read the question. In the meantime, Rita, I would like to start with some questions, also because I saw that in your discussion you talked about several very important issues. So the first of all, of course, is I think that you expect this question because also your very strong background, because as Alberto said before, you're one of the most experts in the Choosing Wisely campaign, in the less is more, but you are also one of the most experts, for example, in the gender medicine and so in the women's health. And so I would like to have an eminent comment from you about the known difference that we observed in our clinical practice about the outcome and about the rate of mortality that is quite different between men and women. And so if you can share a comment or your idea about this.
And are you talking about particularly with COVID, I assume?
Yeah, sure, exactly.
Yeah, it's very interesting. I mean, I think and I'm interested in your thoughts too. The data, certainly early on suggested that men were getting much sicker from COVID than women. And certainly I personally knew, a bunch of couples where the man got COVID and the woman, the wife did not know her husband had COVID, and yet, so they weren't isolating or anything, and she never got sick, and the men were in some cases quite sick and some mildly ill. And even now, I think, as I said, we're dealing with the concerns about myocarditis with the mRNA vaccine in particularly young people, but it is, again, this is particularly in men ages 12 to 24. I mean, most of the cases, and it's still rare, but most of the cases of myocarditis are being reported in young men. So it does seem that in this case, women have a stronger immune response. I mean, that's always, suggested, and, the relationship between the ability for women to be pregnant, have essentially another foreign body, a baby in your system, and not reject the baby, suggests that women's immune responses are different. I mean, we do know that most autoimmune diseases occur more commonly in women than in men, and again, perhaps speaks to the increased vigor or strength of immune response in women. And I think, and this is really my speculation as a cardiologist, that women do have perhaps stronger immune systems and responses, and that was protective, it seemed, overall in COVID. But that's all my speculation, and I haven't seen a lot of scientific data, although I hope we do. I'm interested if you have any thoughts on that topic.
Yeah, I'm one of these examples because I got luckily just a mild COVID form in December, and my partner actually she wasn't infected. So I'm one of these examples, so I'm perfectly in line with your idea. One speculation also that I did. Something that I've read, that it's very pivotal, the role of the right heart in the COVID-19, since basically you have both pneumonia and also thromboembolic disease. So probably, since we do know that women has a better right heart function, and this is the case, for example, on pulmonary hypertension, when we see that women, although they are more affected by the disease, they live longer. So probably one of the aspects, I think, of course, it's something very, very complex, can be that women maybe has better right heart function, and they have also better, they have better immune system. They have also a better, well-structured response to stress, since they are used to, to have pregnancy and delivery. So probably women are more strong somehow of us men. So probably this can be, but I think it's something really, 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 really complex to address, but also very interesting. And coming back to your talk, I really loved the way you addressed it in a very straightforward way, all the aspects of this pandemic that was something very unique in our recent history, and we had to reshape also our world, our daily life. Since you asked for some experiences from Italy, I would say that I was mainly trained in hospital, tertiary centers, academic hospital. Just a very, very small part of my training were done in ambulatory medicine or GP, primary care medicine. And in Italy, we understood that probably we could not have our entire healthcare system rooted only on the hospital, because this is unsustainable. So the role of GPs, it's very important. With a friend of mine, I make you this question to you, which is a bit provocative. It will be very nice if the internist can be, I mean, once you got an internal medicine degree, you can work, even someone can choose to work as GPs. This will probably make the healthcare system more sustainable. And in this COVID was the example, because we received some patients, and I do believe that in the United States, where probably geographically the distance are longer, it was really important, the role of GPs in this pandemic, and probably we have to rediscover it.
Yes, absolutely. And I think, we really learned GPs were central, right, to this pandemic, and so crucial. And I'm interested to hear, well, your experience in Italy in that. I think, in the US, we have so few GPs now. It's a big problem. And I think part of the reason that we overuse so many procedures and have a lot is that we have too many specialists and not enough primary care. There actually was just a change in the reimbursement system in Medicare where they're making some very small adjustments, but going to pay less for procedures and more for evaluation and management services, which is primary care and what GPs and internists do. And I'm hoping that's going to lead to some change, but I think, GPs are so central to healthcare and to patients, and so important. And certainly in the US, we're so under-resourced in GPs. And I'm afraid that trend has been getting worse in the last few decades.
By us, we have probably also not a big numbers of GPs, but the problem is that they have few equipment. Sometimes they don't have the possibility to do a blood gas analysis, which could be very interesting, or even how much helpful was the lung ultrasound also to discriminate those with an important lung. So it will be really nice if probably some GPs could perform lung ultrasound in COVID patients and discriminate those who need an hospitalization from those who are not. But this is probably utopic, I would say. But probably we have to think to reshape our system and making more efforts in, I would say, not only GPs, but direct contact in the local medicine, not only pushing everything to the hospitals, otherwise it's unsustainable.
Right. And I think that the ability to be more trained and have the resources available so that GPs could, shift and do blood gases or, is a big advantage, particularly because what we learned is needs change overnight. And if you have to all of a sudden start training when the emergency occurs, it's too late. You want to have people able to shift from their usual work to what is needed with a little more ease by having had the training in advance and the resources available. So I hope that we have learned from this.
Yeah,
no, it's definitely true. I definitely agree also because in Italy we observe exactly this. So we observe a sort of a failure of the hospital-based, hospital center-based medicine. And I think that, and I hope, as you said before, that when you talk about the possibility to a health reform, that we strongly need to rethink our way to have the medicine and to give importance again to the community medicine. That the COVID-19 showed that how important is the community medicine, not only for the treatment, for the diagnosis, but also for the recognition of patients, for the tracking system that in some parts of Italy was quite good, in other parts no. So yes, I definitely agree that the hospital-based center was not the right answer for this kind of pandemic. So now I read, if you agree, I read some. We have some questions from the from the participants. In brief, I just make a summary because it's a very long question, but I summarize the key points. That first of all is how do you think that our clinical practice and awareness may change after this pandemic? In particularly, our colleagues is interesting in the terms of the fact that we find in a moment in which the EBM was not ready, so we didn't have EBM, and so we were in an unknown scenario with without information about disease, without diagnosis, without prognosis, without treatment, so without anything. So just a comment on this.
Well, it's an interesting question. I mean, I'll give you my view, because certainly we did see an explosion of information. I mean, there were thousands of articles, and we haven't really talked about it, but another thing that changed that we all saw, and particularly in my role as a journal editor, was that we saw more preprints, so that there was a lot more information that was posted because people felt this urgency to get data out there, and would post on preprint servers, which you could do without any kind of peer review. And so that led to a lot of debate. And again, even in a pandemic, I don't think that you have saved time by getting treatments that have not been shown to be effective out there. I mean, there's always this big rush, and particularly accelerated in the pandemic, but I think we always have this feeling of a big rush to have a new drug and a new device or a treatment, particularly for diseases that we don't have currently good treatments. Although sometimes we have lots of good treatments in cardiology, and there's still lots of new drugs and devices that are urgently trying to get on the market. But I think it's very difficult, it's very difficult to have sick patients and not be able to offer them something. That's, of course, we went into medicine to help patients and help them heal. But I still think that, and was even emphasized during the pandemic, that giving patients something that isn't known, that the evidence isn't there, it's going to help them. There's just as much chance of harming them and losing time. And that even in a rush to discover new treatments, we still have to have good data for safety and effectiveness. So that was the lesson I learned. But I must say that I think there are people that think, this means that we should be doing things faster, because, we had some people tend to think, oh, we got a treatment, hydroxychloroquine, things that really didn't work. But I think we wasted a lot of time and a lot of effort and a lot of resources on things like that. And then there were also the concerns, the patients that where it looked like intubations were really making people worse and not better. And, so we were using all those resources. So, and then with the big decline in non-COVID services, we will hopefully be able to look at how people did and use that data to better align resources and better understand the importance of evidence in the care of all patients with COVID and non-COVID illnesses. So that's my hope. I mean, I have a lot of concerns about putting clinical data out on those preprint servers, because even though they have a big watermark that says, not peer reviewed, once they get in the public and in the press, which a lot of those did, people are unable to distinguish things that have actually been tested and peer reviewed and withstood our tests of scientific rigor, and things that have not. And then the explosion of information. I mean, there were just so many articles, and it was really challenging to keep up.
Thank you, Rita, for this point. I will support totally what you said. I always, let's say, fight with my friend physicist or engineer that they use this system archive, which are those papers that are uploaded without peer review. But I mean, you cannot compare, with all the respect for those sciences, with physics or chemistry, whatever, you cannot compare the impact on the media of some medical article with some of quantum physics or chemistry. I mean, that's why I do not believe in this new medkiv where you just write something and you upload. And we should probably fight against those approach. I do not like it. And since you are editor-in-chief of one of the most important journals, my question is, how did you deal with this overwhelming of paper that probably you received during COVID time and probably you still are receiving? It's very difficult to manage. What do you think? It's something that how can we structure better the way that our research groups send paper this very rude way, I would say.
Yeah, those are great questions, Alberto. And first of all, you're right. I think for physics and quantum, engineering, it's the preprint servers do serve a purpose. It's very different for clinical medicine, and I think that is a really important distinction. Yes, in terms of the journal, we had, starting in March of last year, we had double the number of submissions per month as usual. And by May and June, we were at triple submissions, which lasted for the entire year. And we're now back to still twice as many submissions as we've had in the last, our numbers were slowly increasing over the last 10 years that I've been editor, like 10% a year. But we, as I said, were tripled last year and we're still at doubled now what we were pre-pandemic, so January 2020. And that was a huge challenge. And plus one of my editors was also running the New York City Health and Hospital System, so really was working 24/7 on COVID. And so the other editors worked so hard to look at all those papers because, we of course wanted to be sure that if there was something promising like the ones I shared with you in the talk, we wanted to be able to recognize it. But we had so many papers that weren't promising. Robert Steinbrook in particular, the triage editor, I think became an expert in COVID overnight and just did an amazing job at triaging a lot. And I think we all put the out of office papers that said, we are getting triple submissions. And, if you have questions, please just submit to the website because we cannot answer every individual question. But the problem was that a lot of authors felt that their treatment was going to solve the pandemic and therefore we should be publishing it yesterday. And it was very hard to respond to that volume of questions and submissions.
I can imagine how much pressure on you and your editorial board on this. So, that's a EFIM moment. And thank you for sharing with us this.
Well, I think everyone was working hard. Some people were working hard in the hospital, taking care of patients, and we were reading a lot of articles.
We have a question from Professor Nicola Montano, but I don't know if Nicola would like to also pose the question live to Rita or not, or I can read.
Oh, that would be wonderful.
Hi, Nicola.
Hi, Rita.
Oh, Nicola, it's so good to see you.
Very good to see you. Thank you so much for the time that you dedicated to us and to our young internist. So I think that we share a tragedy altogether, but I would like to ask you something about the socioeconomic factors, because, I think that beside all the clinical and more clinically related aspect, this pandemic highlight very clearly the importance of the socioeconomic factor as determinants of health and of course disease. And it's data says that the lower income classes were the more hit by the COVID. Okay, and so now let's say that we may act. This is the time to act. So what you would like to suggest to a politician to put in the agenda in order to address the problem of the socio-economic determinants of health? Because the problem is that, of course, we know that we can highlight different things that can be good or bad for health, but preventive medicine is a political issue, as you, of course, sustain from the pages of your paper for many years. So, but let's say that now is a moment in which maybe there are some ears that are listening to us. At least we should try. So in your opinion, what are the most important suggestions that you would like to give to politicians to modify, these inequalities? I know it's a $1 million question, but
it's a great, I mean, you think the big thoughts, Nicola. I mean, that really is.
Try. I think that this is our moment to try to to think big.
Absolutely. I mean, and I think you're right. I mean, certainly you mentioned prevention. And so, and I already said, I think, public health, and of course the emphasis on, I think we need to have equal access to healthcare. We have to have, everyone is entitled to basic healthcare. But more than that, I think this pandemic really pointed out the inequities and how disparities in all parts of life, housing, economic opportunities, living situations, make such a big impact on health, because all of those, I think, need to be addressed. We need to have living wages for everyone. We need to have good housing opportunities. I think the fact that, and sadly, certainly in the US, income disparity has increased so much, where we have just, the fantastically wealthy, and then so many people that don't have the basics of, what all humans should have, a roof over their head, good food, guaranteed food security to eat, and clean water. And the fact that we don't have that, and that there are clear racial and ethnic disparities in access to basic human needs is urgent. And it really sort of lit up at the same time as the pandemic. We had the George Floyd murder and the Black Lives Matter movement really highlighting, how there are still existing racial and ethnic disparities, and how that we're not going to get to a better place for all until we really recognize and address those. And I do hope that there is, progress, and that it is right, the time for politicians to recognize that. I fear that we'll just go back to business as is, I think. And certainly the questions, the recent, the ProPublica story last week, where they took like the 20 top billionaires, which are huge, multi-billionaires in the US, who pay less taxes than like 100 and,
Yeah, nothing.
It was just remarkable. I mean, the disparities in the system, and obviously that, even I think with charitable donations, it doesn't go to redressing. I think there has to be a government social support system for everyone. And this is what my dream would be, is to see that change, and that, guaranteed basic healthcare and basic housing and food for all. Yeah. What are your ideas, Nicola?
No, I think
thought about it clearly.
I think that this is our next battle. The battle that we as a physician, because a physician, there is a very famous Latin comedy by Plauto, Del Miles Glorioso, to say, I'm a man, and so I'm interested in everything is human. And so I think that as a physician, we have somehow, we are advocate of our patient, but the patient are citizens. And so, I think that we should try to do all what we can in order to put pressure on the politician, in order to realize what is exactly the key issue. Because I know that you are very aware about the FDA approving a drug that really was really a sort of debacle of all system, and so spending a lot of money while then you don't have the basic the basic needed, the basic drugs and the basic access to healthcare. So this is something really, that's really struggled me. I have to tell you that really struggled me. It's totally not only counterintuitive, but in these days, it is almost offensive.
Mm-hmm.
And of
Yes.
course, I can well understand all the people with Alzheimer's disease. I can well understand. I have friends who have parents with this. But this is not, it's not the right way to do it. It is not creating a hope without any data that we can help them.
Right. Exactly. I mean, who knows what will happen, but it certainly could happen that this drug, that both trials were stopped for futility, there was no benefit, there was a considerable incidence of brain swelling, and then gets FDA approval against the advice of the entire advisory committee, and then is priced at $56,000 a year. I mean, people can live on that much, right? Or you could say, I mean, there are proven therapies for Alzheimer's now, right? Besides, all the things we were just talking about, we know that, people that get good food and good exercise and, are much less likely to get Alzheimer's, but also there are programs. We published a study called the CARE program, where they basically just had increased caregivers. So home health aides that were able to go and work with older patients, and they had decreased progression of cognitive decline. And those things cost, a fraction of what it costs for this drug that is more likely to be harmful than helpful. And yet, Medicare will pay for a drug that doesn't work, but they won't pay for, help for, for caregiving, for simple things that people can put in their homes to make living at home, more like the thing in the shower so that old people can hold on to the shower. I mean, these things that clearly make life better for older people than this drug. So it really, every time I think we're making progress, something like this happens. And now people are saying maybe this will be, I've heard it called the 9/11 moment, in healthcare, where we'll say, what are we doing? How could the FDA be approving these kind of drugs and then Medicare be paying ridiculous prices? And
yes,
we don't have time to talk about the lack of any kind of relationship between a value in a drug and the price in the US.
And Rita, thank you. I have another question, very small. Another vicious, something that in my opinion, it's related to, what's happening what's happened and what's happening in healthcare is that there is too much specialization and a very, very small space for generalistic view. But now we dramatically need generalism and not specialism. And as internist, of course, which is the most holistic and generalistic specialty, what do you think about this? Because I really, what I missed is a generalistic vision of healthcare and of the approach to the patient.
Absolutely. I feel like, that analogy where there's an elephant and everyone's looking at some tiny little part and describing this is a tail, and nobody sees the big picture. And to me, that's what the generalist does. And it really is more healthcare is not better, because I see so many patients now that have a specialist for every little part of their body and no generalist, nobody who's looking at the big picture, nobody who, are doing things like seeing that they're on, too many of one medication, not enough of another, or just too many medication, or also just looking at the big picture. This is all because there was some terrible family event and it wasn't really a chest pain. It was, a depression from, we need generalists. And I think it's what patients want. I mean, patients really want generalists who know them, who I think the healthcare is just such higher quality when you know your patient, you have a relationship with your patient, and then you understand what's going on, and it's better for patients and better healthcare. And generalists are so important, and I think it should be the focus of training and resources in generalists, because that really is the key to medicine. And I think a lot of the problems, particularly in the US, is that we've moved towards way too many specialists and subspecialists. We focused on the trees and missed the forest.
Yep. Thank you.
Thank you.
Thank you
I
so
do
much.
hope that one of the other sad things of pandemic was I didn't get to come to
Yes,
Milan. I'm
not
hoping
yet.
next year
Not
I
yet.
can be
For sure in 6-9 months.
I see also
Hi,
Rita
Rita.
Capellini.
Hi, Rita. I just
Oh,
want to
Nika,
say
it's
hello
so
to
good
you.
see you.
Tonika.
And I thank you for your insight. Your presentation was very inspiring. So thank you very much. We have so many things to discuss. So we hope to have you in Milan soon, actually.
I am so looking forward to it. I'm really excited.
Thank you.
Thank you. Great.
So
Okay, well,
I think, of course, this webinar, I wish it could last for hours, but I think that
forever.
Redberg has a long day. We are almost closing our days, but probably she's just at the beginning. And so we thank Professor Redberg for this amazing talk and amazing discussion. We're looking forward to see her probably live, probably when she will be hosted in Milan by Professor Montano next year, and probably also if we have the chance to invite her in Napoli and for all the internists in Italy. And thank you really for giving us this huge opportunity to listen you and your vision. And it's very thanked on behalf of the young internists in Italy and Europe. Andrea, I don't want to know if you want to say something.
What else I can say after this? So it's true, it's definitely inspiring. I want just to add another thanks, because I saw that in her presentation she shared some picture of our city, of Naples. So she touched our hearts. So
thank you so much, and I hope to visit in person next year.
And we will be very happy to
have you
and to host you.
Thank you so much for this
Rita.
invitation.
Thank you also to the audience.
It's inspiring to me to talk to all of you. Thank you so much.
Ciao.
Thank you.
Thank you.
Bye.